Hi, I'm Steve Henson, and welcome to Q&A. This is our newest idea to make what this prostate cancer journey, which kind of sucks, a little bit better. And you don't want to be in our club, but this is what we've got for you. So I'm a 12-year survivor and the co-founder of the Prostate Network.
Hi, I'm Shen. I'm a radiation oncologist. I've been practicing for about 10 years, and I'm really excited to do some Q&A.
All right, so let's dive in here. Most of these questions are for you tonight, but down the line, I think we're going to get questions all over the place. So if a guy had prostate cancer, when should he start getting checked?
So that's a really good question. And if you ask different people, you're going to get different answers. So a lot of people go by the U.S. Preventative Services Task Force recommendations. So that's the group that sets out your screening recommendations for, anything, breast cancer, all the different screening recommendations. Well, it turns out that they say that basically the only men who should get screened, we even think about screening, is age 55 to 70, and that very select group. And a lot of primary care doctors go by that. That's kind of their playbook. However, if you look at the National Comprehensive Cancer Network, so this is like a group of the most esteemed cancer hospitals across the country. The experts get together and make recommendations. Their recommendations are a little bit different. And what they recommend is for men age average risk, okay? Average risk of prostate cancer, age 45 to 70 should be screened for prostate cancer, or at least evaluated for prostate cancer. However, if you have a little bit higher risk, and that higher risk could be African American race or family history, or if you're known to carry a cancer-causing gene like the BRCA gene, then those patients are recommended to get, those people are recommended to get screening starting at age 40. So depends who you believe. Now, as a cancer doctor, I really go by the National Comprehensive Cancer Network guidelines. So if there's a strong family history, I think starting at age 40 is probably what makes most sense. And one of the things I just want to expound on that a little bit, a lot of people think about prostate cancer as being not that lethal. Well, if you're a non-smoking man in the United States, your number one, the number one cause of cancer death in a non-smoker is prostate cancer. And so it's not something we should, just kind of ignore and consider not that worrisome, because it is a big problem.
Yeah, and I'm going to add that, I was 46 when I was diagnosed, and I didn't find out for a year after I was diagnosed that I had a family history. I didn't ask. I didn't know to ask. So you've got to ask, guys, and that's really the only way to know for sure. So, all right, excellent question to kick it off. So here is one for someone who's been diagnosed. If they can spare one side of the nerves, can you still get an erection?
So the short answer is yes. But it's all about probabilities to some extent. So if you're able to spare both sides, your likelihood of recovering and being able to have erections down the road is better than if you only can spare one side. So but it's also like the decision to spare one side or both sides. It's you have a trade-off, right? If you have cancer that's highly likely to have spread outside of the prostate on one side, and you spare it, you have a higher chance of leaving cancer behind, which would end up requiring more treatments. So that decision making is important to think about. That said, yes, people can still have all you need is one side of the nerves. You can still have erections if you only have one side of the nerves. Not as high likelihood, but it's still possible. So I'm not a urologist, okay? I'm a radiation oncologist. But I work with urologists a lot. And for a guy who's completely normal, now nobody thinks they're normal like they were when they're 20, right? But what doctors mean when we say normal is you're able to achieve penetration without needing medication. So that's normal. And so if you're normal and you save one side of the nerves, we think maybe 50% chance of keeping your erections down the road.
Okay. All right. Tables turning.
All right. So, Steve, I know you guys have had a meeting recently with the survivors to talk about, different advice. And so, what are some of the insights the survivors have that really were really beneficial for them that the doctors didn't really talk about? Like, what were the kind of insider tips that survivors had that they'd learned through their journeys?
Yeah, I was excited to take that to our meeting last month. We've had different people providing care, research, all sorts of people want to ask our group questions. And that when I posed that we were doing this, our guys were like, "This is great," and they had specific ideas on what can you do if you get in our club. And I was heartwarmed with their response. They all chimed in. They're like, being a part of this group, they could talk to their spouses and their friends, but to be able to talk to other men that were dealing with the same thing was incredibly important to them. And so their advice was, to find a group in your area. If there's not one, especially now, kind of COVID silver lining, we're hybrid, so people can join us. So be a part of the group. But then they also had specific things too. They wanted you to know that, the diet and exercise, how important they are. They are in your control. And there's so much of this journey that's not in your control, and how important it was. Like the number one and two things you could do to combat depression, which prostate cancer is pretty depressing, is diet and exercise, and so do whatever you can to clean those up. And they also wanted men to know that you have to ask about sex. So there's going to be side effects to these treatments. The earlier you catch this, the less the side effects are from the treatments. But nevertheless, even for the most aggressive cases, it's a subject that too many men have failed to bring up, and too many providers have failed to really want to dive into. Nobody wants to talk about it.
Yeah.
But everybody wants to do it. So you got to do that. And lastly, they wanted to make sure people knew to find a reliable source. There's a lot of sources of data, and we do our best to filter through it. But like Prostate Cancer Foundation, the Prostate Cancer Research Institute are excellent sources, those two in particular. And so find some really reputable sources of data to read, and don't get kind of caught up in the thing. So
yeah.
Those were really good, and looking forward to people submitting questions that we can take to this group again. So now back to you. So does radiation to the prostate increase your chances of developing colon cancer?
So that is a fantastic question. And so actually the data for that, there's not that much data, because you got to remember, men who are diagnosed with prostate cancer, average diagnosis 66. And a lot of people treated with radiation a little bit older. And so you don't necessarily have the long-term follow-up data that you would need to answer that question. However, we think based on some other data from other cancers, treated in the pelvis, that there is probably some increased risk of secondary cancer in the areas that got radiation. And there's some hand-wavy retrospective data that suggests that maybe there is a little increased risk of rectal cancer or bladder cancer if you got prostate radiation. So there's a thing that we consider when we think about risk of relative risk and absolute risk, right? So relative risk is how many times more likely are you than if you got it than baseline, how many fold, and absolute risk is how many actual percentage difference there is. So we think, to the best estimate that people can do, it increases in the tissues that get radiation. So the rectum that's right around the prostate, the bladder that's kind of around the prostate, the tissues that get radiation is probably has a relative risk, twofold relative risk, meaning those tissues are probably twice as likely to get cancer, develop in those tissues compared to if you never got the radiation. However, because it's so unlikely for you to get cancer in those areas, even though it's a doubling of the relative risk, the absolute difference, how much you're actually more likely, how much you're actually likely to get cancer is actually really, really small. And lots of studies been done. Most of them have not been able to show a difference because the numbers are so small.
Fascinating. It was a good question. So our last question today is Gleason scores. What do those numbers mean?
Yeah. Oh man, this is people get this question. We get this question asked a lot, and it's really important to understand that because it's such a fundamental part of our, the cancer and cancer diagnosis and so forth. So Dr. Gleason was this pathologist over at Johns Hopkins University who kind of first developed the scoring system. So it's important to understand there's the Gleason score, and then there's the Gleason grade, and they're slightly different. The grade goes from 1 to 5. Okay, 1 being the kind of the least aggressive looking, and then 2 a little bit more, 3, 4, and 5. 5 being the worst. Well, nowadays we don't think of 1 and 2 as being cancer anymore. So it's really only Gleason pattern 3, 4, and 5. Okay. Now it turns out that when you do a biopsy, the cancer doesn't all look the same. There are parts of it that look, can look one way, and other parts that look a different way. So the Gleason score it's a two numbers, right? It's a first number plus a second number. So the first number is what it mostly looks like, and the second number is what like a smaller portion, like the minor portion, looks like. So the first number is let's say it's a 3 plus 4, right? So most of it would be looking like a 3 pattern, a little bit looking like a 4 pattern. And we add the two together, that gives you a Gleason score of 7. But the type of 7, whether it's a 3 plus 4 or 4 plus 3, make a pretty big difference. Now, since I think last couple of years, we've actually changed it to a group, a Gleason, like a grade group now. It's not exactly a Gleason, it's a grade group. And it's because people were always really confused, right? Because the Gleason 6 cancer is the least aggressive cancer, and Gleason 10 is most aggressive. But 6 starts in the middle, and that seemed to be confusing for some people. So we changed it to group 1 to 5. So 6 is group 1, 3 plus 4 is group 2, 4 plus 3 is group 3, 4 plus 4 or some combination of 8 is group 4, and then 4 plus 5 or 5 plus 4 or 5 plus 5 is group 5. So, but overall, basically, the Gleason score is how aggressive the cancer looks under the microscope, and the numbers add up to describe how aggressive it looks.
Wow. Well, thank you for doing this. I think we're going to answer a lot of questions. Yeah. And folks out there, please submit your questions, prostatenetwork.org/QA, and we will fire this up again. Thank you all.
All right.
Bye.
Thank you guys so much. It's been a pleasure to talk to everybody.